Viktor Frankl spent decades working with patients in suicidal crisis. He had a particular intensity about this work because he had himself, as a young man, considered ending his life during a period of acute meaning loss, and his recovery had partly motivated the development of his entire psychology. Frankl's approach to suicidal patients differed from much of standard psychiatry in one decisive way. He refused to treat the suicidal impulse primarily as a symptom to be suppressed. He treated it as a question to be answered. The patient, in his view, was not malfunctioning. They were asking, with maximum seriousness, whether their life had a reason to continue. Logotherapy's task was not to talk them out of asking the question. It was to help them find an honest answer. This required a kind of clinical courage. Frankl reports cases where he sat with patients who were entirely clear about their intention, and instead of immediately referring them to medication or hospitalization, asked them the question they were asking themselves: what would make your life worth living? Often this was met first with anger or silence, sometimes with bitter laughter, as if the question itself was naive. But Frankl would sit with the silence, and the bitterness, and the anger, and the question would remain. In one documented case, a patient came to him after his wife and child had died in an accident. He explained that he had nothing left to live for and intended to end his life. He had come to Frankl essentially to formalize the decision, to confirm that there was no contrary argument he had missed. Frankl did not argue with him. He listened carefully. Then he said, if your wife had died first, leaving you to raise your child, and your child had died after some years, you would have spared your child the loss of her mother by being there for her. Your child died first. You spared your wife the loss of a child. The grief you carry is the grief you carried for her. By living, you are continuing to spare her something, by carrying it on her behalf. The patient sat for a long time. Then he wept. He had not seen his suffering as having any value. Frankl had not denied the suffering. He had offered a way to perceive it that gave it a kind of meaning. The patient did not end his life. He returned to work, and saw Frankl again several times, and built a different life across the years that followed. This was Frankl's method. He did not minimize the suffering. He did not promise that things would feel better. He did not offer optimism about future outcomes. He worked, instead, to help the patient find a meaning that was already present in their situation, if they could see it. Sometimes the meaning was a task that only they could perform. Sometimes a person who needed them in a specific way. Sometimes the attitudinal value of bearing what could not be changed. Frankl's three categorical values structured his clinical approach to suicidality. With the patient who reported nothing left to live for, he asked first, is there work, of any kind, that is yours to do? Most patients could find some honest answer. Then, is there any person for whom your existence makes a meaningful difference? Most could find at least one. Then, when the first two failed, is there any stance you can take toward your suffering itself that would constitute a meaningful response to what you have been given? This third question was harder to answer but, in the most severe cases, the only one that could be answered honestly. Frankl was clear that this approach was not for every clinician or every patient. It required a specific kind of clinical relationship and considerable training in logotherapeutic technique. It would be irresponsible for an untrained therapist to apply it without preparation. But he insisted that the underlying principle was sound. The suicidal patient was asking a real question. The right response was not denial but answer. Frankl's own writing on this work was sober. He recorded the patients he had helped and the patients he had not. He did not claim perfect success. He claimed only that some patients, in some moments, could find meaning where the standard clinical approach could not have helped them find it, and that some of these patients went on to live the rest of their lives reporting that the conversation in his office had been one of the most important of their existence.